Yes,
sir.
Yeah.
10 minutes you will join, he told, sir. Uh, Good evening, everyone. We are live on YouTube. Uh, Welcome to the second hip arthroscopy meeting of IAS webinar series. We have with us Professor Soshi Uchida. He is the head of Sports Injury and Arthroscopy Department of Wakamatsu Hospital, Japan. He is a specialist in hip arthroscopy and godfather of and Isako's Teaching Center Director of Japan, only two centers in Japan. Along with Professor uh,
Yes.
Dr. Hirotaka Nakashima will also be joining us today for his second talk. He is a super faculty at Wakamatsu Hospital and he is a sports doctor certified by the Japanese Sports Orthopedic Association. To moderate this session, we have Dr. Prashant Tonape sir, along with that, Dr. Ayyappan sir will also be joining us to moderate this session today. We have with us Dr. Rajiv Raman sir, who is the Secretary of Indian Arthroscopy Society, and myself, Dr. Krishna Naresh and Tirth Vyas. We are the webinar coordinators. Over to you, Soshi sir, and Prashant sir. You can moderate the meeting, sir.
Okay. So, sir, you can join. Start your talk.
Okay. Thank you very much for having me. It's my great honor to talk about optimized light patient selection for hip arthroscopy. This is my disclosure. Today's agenda, how to diagnose indication, hip arthroscopy, and contraindication. This is the showcases of 69 years old female patient complained left hip pain presented to us for further consultants. So you can see here the X-ray showed lateral theta angle 25 degrees, Tonus angle 11 degrees, and the VCA angle is like an anterior acetabulum center edge angle is 21 degrees. And the joint space looks healthy and suggesting borderline hip dysplasia. So MRI showing T2 star columnar view showing anterior superior labrum tears, but MRI proton fat suppression and T2 mapping showing, you can see here, the gray zone is a normal, suggesting a normal cartilage, but white zone is a defect of the cartilage. And the T2 mapping showing a defect of the blue zone, suggesting cartilage damage. And what we found is arthroscopic findings showing labrum tear and the cartilage damage at the femoral head. And we performed the labral repair and FA correction and microfracture for the femoral head cartilage damage. So what happened to this patient? Preoperative X-ray showing good, but 3 months after surgery, she started complaints left hip pain, and 9 months after surgery, it's a joint space collapsing. And finally, consequently, she need to conversion total hip arthroplasty. So we have to avoid this catastrophic failure of hip arthroscopy. So main purpose of this lecture focuses on the key factor to consider when selecting patient for the hip arthroscopic management and optimize right patient selection. Understanding the indication and contraindication for hip arthroscopic surgery is really crucial. Proper patient selection can lead to improved outcomes and reduce complications. Who is a good candidate for hip arthroscopy? Young active athlete, intra-articular pathologies such as FAI, acetabular labrum tears, condylar damage is localized condylar damage, and synovial osteochondromatosis. And stepwise optimized right patient selection is history, physical examination, imaging, and intra-articular injection, and physio. Those categories is really crucial to identify the right patient selection. History. This is the Dr. Croce's group studies looking at where patient pains comes from. The FAI patient complains not only groin pain, but also buttock pain, low back pain, and knee pain. You can see here, 88% of the FAI complains the groin pain, but low back pain in 23%, and buttock pain 29%, and knee pain in 27%. So this is the Doha Agreement meetings showing they divided in the groin pain to two categories, extra-articular and intra-articulars. The extra-articulars define the clinical entity for the groin pains. Number one, adductor-related groin pain. Number two, psoas-related groin pain. Number three, inguinal groin pain. And number four, pubic-related groin pain. And intra-articular groin pain consists of hip joint-related groin pains, such as FAI and labrum tear and hip dysplasias. Actually, in my experience, those related groin pains considerably overlapping. You can see here, this is MRI showing pubic bone marrow edema pattern, and you can see the yellow red arrow suggesting inferior cleft signs suggesting adductor tear. So adductor related and pubic related groin pain. This patient is a 17 years old soccer player, male soccer players. The X-ray showing pubic abnormalities, X-ray, and bump at femoral head and neck junction suggesting cam impingement. This is our studies looking at clinical outcomes of FAI, arthroscopic FAI correction and labrum repair surgery for the treating a soccer player with FAI. The soccer player FAI is 67.8% had X-ray abnormality of pubic symphysis, and 35.7% had a pubic bone marrow edema pattern on preoperative MRI. But after surgery, at 6 months after surgery, all findings diminish after FAI correction in all cases. So we consider the constraint or range of motion of the FAI contribute contribute to transverse stress at the pubic synthesis, predisposing pubic osteotis pubis. Physical examination. This specific test, the physical examination, is really crucial. In my hand, Faber test is Patrick test is placed here on the side to be examined on the contralateral knee joint. And you can see here a limited external rotation and flexion, suggesting hip intra-articular pathologies. And this is the Fadia test, the flexion, adduction, internal rotation test. The pain elicited by the flexion and the internal rotation of the hip joint. And the log roll test is the hip dial test. The patient lying on the supine position and the external rotation by examining. and ankle dorsiflexion at 0 degrees. You can see here, left side is normal, right side is unstable, suggesting extensive labrum tear or capsular laxity problem. So those differential diagnosis is really important to distinguish extra-articular and intra-articular pathologies. If the patient has a physical examination, the limited range of motion, and a positive fiber fatigue and local hip dial test, and the local anesthesia injection, the intra-articular injection is effective, we can consider those patients as an intra-articular pathology. On the other hand, limited range of motion is negative, and fiber fatigue at hip and hip dial test is negative, and the local anesthesia injection is ineffective. We consider those patients as extra-articular pathologies. So, and the imaging is really important, but Dr. Nakashima is gonna talk about imaging today. So I'm gonna skip the imaging, and then intra-articular injection. Intra-articular injection of local anesthesia can identify and understand where pain originated from. This is ultrasound findings. This is the femoral head. This is the anterior inferior iliac spine. You can see here, the needle go into the capsule, not intra-articular, intracapsular, and then intra-articular injection to 1%, 5 ml or 1% of mepivacaine, and sometimes include cortisone. And we usually utilize a 23 gauge of the needle. This procedure is safer, advantage of the safer and no radiation exposure compared to the intrafluoroscopic injection. So distinguish the hip joint pathology from SI joint and supine lumbar spinal disorder is really important. So intelligence injection of local anesthesia is really invariable. If the patient have both hip pain and low back pain, start low and go high. That means start hip joint first and SI joint and lumbar spine. This means if the injection is the hip joint, it's the 100% of pain gone. The low back pain sometimes comes from hip joint, caused by hip joint. Those patients have can be treated by can be managed by hip arthroscopy surgery. So also intelligent injection algorithm is intra-articular pathology versus capsular pathology. Intra-articular injection first, and if 100% is effective, we consider only intra-articular pathology. However, non-effective, sometimes intra-articular injection is needed. And if the 100% effective, the patient have only extra-articular pathologies. If the intra-articular injection is partially effective, maybe patient sometimes complain, okay, the 30% of the pain relief or 50% pain relief. Extra-articular injection, and sometimes both extra-articular and intra-articular pathology is overlapping. And then patient try physio. This is our studies looking at the randomized controlled trial comparing the conservative treatment with trunk stabilized exercise to the standard hip muscle exercise for treating femoral acetabular impingement. This is published in the CJSM. And what we found is the trunk stabilizer exercise group the patient have to do a plank exercise and bird and dog exercise. But another group, the hip muscle exercise group, is only abductor and adductor and flexor exercise. And we found IHOT trial and bio hip scores significantly improved compared to in trunk exercise group compared to control group. So next, we're gonna talk about contraindication. Contraindication of hip arthroscopy is hip dysplasia, osteoarthritis, and osteoporosis, obesity and BMI greater than 30, opioid consumption, and mental disorder. This is a study looking at clinical and radiographic predictor for worsened clinical outcome after hip arthroscopic labrum repair and FAI correction surgery. It is published in AJSM. And we perform a labrum repair and camosoplasty and closed the capsule. However, 31% failed hip scope at two years after surgery. And we found predictor for poor clinical outcomes are broken shenton line, severe cartilage damage, BMI greater than 23, femoral neck shaft angle greater than 140 degrees, and lateral center edge angle less than 19 degrees. Those patients have a predictor for worsened clinical outcome. Opioid use. This is a study looking at the opioid use association with clinical outcome after hip arthroscopy. 22,124 patients are included in these studies. This is the Pittsburgh studies. And the preoperative opioid use 31.2%. And averaging about 4 milligram of oral morphine equivalent per day is 11%. And the adjusted perioperative cost is significantly higher in opioid use group. And the revision rate of hip arthroscopy is significantly higher in opioid group. Total hip arthroplasty rate is no significant difference of the both groups. And acute post-operative opioid usage is much higher in compared to the control group. And emergency department visit is significantly higher in opioid group. So these findings guide the initial effort to mean opioid use in the patient preparing for the surgery and bring forth on the longitudinal interdisciplinary effort of opioid advance and early reference in patient with FAI. And this study is showing a risk factor for THA conversion after hip arthroscopies. And what they found is independent risk factor for revision surgery on conversion to total hip arthroplasties are age over 60 years and lower volume surgeon and female sex and obesity and the presence of pre-existing arthritis. This is Dr. Nakashima, our study is looking at if the patient have a tonus grade 1 FAI compared to the only FAI group, we found 50% of the patient in FAI plus OA group need total hip arthroplasties. So even though if the labrum repair is we perform the labrum repair, but we cannot solve the no benefit from hip arthroscopy. This is also age related. There are several studies looking at age. Over age 65 or over 50 years old those patients is 70 to 20% need conversion to total hip arthroplasties. So risk factors should not discourage the patient. It is important to note these risk factors should not discourage the patient from considering hip arthroscopy as a treatment option. Rather, they provide valuable insight for the surgeon, the patient alike to set a realistic expectation to develop appropriate treatment plans based on the individual circumstance. This is our studies looking at clinical outcome, 17 years patient without osteoarthritis. Arthroscopic FAI correction hip surgery provide favorable clinical outcome after hip arthroscopy for 78. You can see here, this is published in the KSSDA. We divided the both patient into three groups. A younger group, younger than 50 years old, middle age group, 50 to 69, and advanced age group is the patient older than 17 years. We found patient-reported clinical outcome score significantly improved in each group. The rate of conversion to total hip arthroplasty are higher in the middle group, means 50 to 69 years old, but no patient required total hip arthroplasty in the 17 years older the patient. And obesity or higher the BMI has been associated with increased risk factor of conversion to total hip arthroplasty. The pooled odds ratio was 22.4% for conversion to total hip arthroplasty if the BMI is greater than 30. So take home message. Understanding risk factor for conversion to total hip arthroplasty after hip arthroscopic treatment for the FAI is essential to optimize the patient outcomes. Factors such as age, pre-existing OA, and higher BMI can help identify patients who may be at a higher risk of requiring TEGA in the future. Be considering these factors, practice can personalize treatment approach and provide the best possible case for the patient with FAI. Thank you for your attention. This is the advertisement ISHA 2025 in Japan. Will be held in the next year, October 2nd to 4th. Please save the date and please come to Japan to join the ISHA. Thank you.
Thank you, Dr. Sochi.
Thank you.
Just can I ask one question? Hello?
Hello?
Can I ask one
Sure,
just
sure.
your opinion about the hip pain with early avian cases?
I'm sorry, can you say it again?
Early avian cases, early avascular necrosis of the femoral head,
Yeah,
grade 2, grade 1 to grade 2. There is a
yeah,
synovitis and there is a hip pain, bone edema, and there is a starting of the necrosis.
yeah.
So what is your take on here about the hipscopy?
Okay, that's a great question. If the localized small, less than 50% of the region of the femoral head, sometimes try to perform the hip arthroscopy for treating those cases. And SIF means subchondral insufficient fracture is sometimes uh, sometimes similar finding to femoral head necrosis. So those patients, I fix the label. So those patients, I try to perform the hip arthroscopy. We found all patients have a labrum here. So we fix the labrum, and if the femoral head necrosis, we perform retrograde drilling from greater trochanter to the femoral head approaches and curettage the necrosis region and puts a stop in the bone marrow cancerous bone stuck into the region. That can be sometimes helpful.
Okay. So I wanted to share my experience in this. We performed around 20 cases, 20 to 20, I think 23 cases we performed up till now. The before doing the core decompression in grade 1 to grade 2 cases. So there is a before doing the patient is on a traction table, and we are doing before doing the core decompression, we scope the hip first. So the patient, these all patients got the pain relief because of the two reason at what I am assuming, the because of the core decompression, and we are putting this thing, bone marrow injection and BMAC injections, and the other thing is the tamponade effect of the capsule decompression synovitis, that kind is a so the patient
I
is
agree.
totally if and in that around 7 cases I found there is a lesion on the acetabulum, some kind of lesion, cartilage grade 1 lesion. So we just did a radio frequency ablation of the lesion, and patient is improved with pain. There is actually no pain at all, and that patient is in still follow up. They not went in another stage, and the process is halt there only, I think so. So let's see, the paper is coming on that issue. So I just wanted to know about your view on the hip scopy in avian cases. So like that, there is a hip pain and there is a groin pain also in grade 1 and grade. A lot of groin pain patient is very in pain. So after doing the hip arthroscopy, just there is a release of that pressure, intra-articular pressure, and that is a tamponade effect on the head, the bone edema. So that is, I think, the cause of the pain relief.
Okay. Thank you.
Okay, thank you. Okay. Then, Naresh, I think we are going to the next lecture.
Yeah.
Okay.
ゆうたか大丈夫
OK です。
Okay, welcome, doctor.
Next talk is by Dr. Hirotaka Nakashima. He will be speaking about plain radiographic parameters of FAI. Welcome, Dr. Nakashima.
Okay, can you see my presentation?
Yes, we can see your presentation and we can hear you clearly.
Okay.
スライドショーにした方がいい。スライドショーにした方がいいよ。スライドショーにした方
がいい。Thank you for giving me this opportunity. My talk is plain radiographic parameters of FAI. I have nothing to disclose. This slide shows the diagnosis criteria of FAI in Japanese hip society. Diagnosis criteria of FAI consists of two factors: radiographic findings and physical findings. So, radiographic evaluation is needed to diagnose FAI. However, don't let radiographic findings decide surgery. This is most important in my presentation. This slide shows our routine radiographic assessment. We usually take epipelvic view, cross-table lateral view, modified down view, and force profile view. These slides show the radiographic parameters and characteristics which we usually evaluated on AP view. Once again, I will show the diagnosis criteria of FAI. The diagnosis criteria of FAI of pincer region are C angle more than 40 degree, C angle more than 30 degree, and axial roof oblique or twin angle less than 0 degree, or positive crossover sign and let's C angle more than 25 degrees. So AP view is necessary to diagnose pincer impingement. Normal range of lateral center edge angle is from 25 to 39 degrees. More than 40 degrees indicates a pincer region, and less than 25 degrees dysplasia. A normal range of twist angle is from 0 to 10 degrees. More than 10 degrees indicate dysplasia, and less than 10 degree pincer lesions. Femoral epithelial acetabular roof index is reported in 2070s. It's useful to evaluate the instability in borderline hip dysplasia. Fear index is an angle between acetabular inclination and physical scar. More than 5 degrees indicate instability. Delta angle is also useful to evaluate the instability. Normal range is more than 10 degrees. Crossover sign is also indicates the focal acetabular overcoverage, which indicates the pincer region. And it also indicates the acetabular retroversion. Prominent posterior wall sign indicates the posterior segmental pincer region. False profile view is useful to assess the anterior coverage and AIS. It's also useful to evaluate the osteoarthritis. False profile view is taken like this slide. 59 years old female with right hip pain, and joint space narrowing is not clear on AP view. But false profile view shows the joint space narrowings. So false profile view is useful to evaluate the osteoarthritis. This shows the check study. Check study is a famous study which indicates that dysplasia is a cause of hip osteoarthritis. And dysplasia has been known as a contraindication of isolated hip arthroscopy. This result describes just before my presentation, so it skips. So this is a 23 years female with left hip pain. Her LC was 5 degrees and Shenton line was broken. Femoral neck shaft angle is 141 degrees. So this case is not a good indication of isolated hip arthroscopy. Next, with diagnosis criteria of FAI. How to diagnose the CAM region exactly? Alpha angle is usually alpha angle more than 55 degrees is defined as a CAM region. And pistol grip deformity it also indicates the CAM region. The growth abnormality of the femoral epiphysis is known as the cause of CAM region, and SCFE, LCPD, and fracture healing are known as the secondary cause of CAM regions. And CAM region is a cause of hip osteoarthritis. And recent study reported femoral osteotomy femoral osteoplasty is necessary for achieve the good outcomes. So to perform the femoral osteoplasty, to identify the CAM region is necessary. Moreover, residual CAM is the most common reason for revision hip arthroscopy. So to identify the CAM region is important. So we take our down view. Down view is useful to evaluate the CAM region. We recommend to take not only cross-table lateral view, but also take a down view. Modified down view is taken flexion 45 degree and external rotation 20 degree, and flexion 45 degree and external rotation 45 degrees. Finally, osteoarthritis is known as a contraindication of hip arthroscopy. This systematic review reported tonic grade more than 1 grade and joint space less than 2 centimeter, high risk of conversion to THA. And our study also indicate tonic grade more than 2 is high risk of conversion to THA, and clinical outcomes were not significantly improved. So the indication of arthroscopic treatment for FAI with osteoarthritis is limited. Osteoarthritis should be checked not only AP view, but also false profile view. In conclusion, radiographic evaluation is necessary to exact diagnosis. Radiographic parameters can predict poor clinical outcomes of hip arthroscopy. Thank you.
Thank you very much, Dr. Nakashima. It was a wonderful presentation. I would invite Dr. Ayyappan sir also joined as a moderator for our session today. Any questions from any of the panel can ask. Purnachandra sir, any questions?
I'm good.
Okay. Nakashima, I would like to ask you one question. In
Yeah,
case
okay,
of
thank you.
in case of a cam deformity, if I ask you to look for only one angle, which is diagnostic of cam deformity, which we can take to see preoperative and postoperative for measuring the functional outcome. What is the thing? Which
Uh,
angle you have to see?
I'm sorry.
Which angle? Only one angle.
Yeah.
If I ask which is the most important to look for in case of a cam deformity.
どこの角度で、レントゲン撮って一番いいか。
As usual, cam is 11 o'clock is the most of 11 to 1. I'm sorry. Clock operation position. One is the most popular cam deformity. So
Okay, let me explain.
Okay.
Okay, so you're asking post-operative X-ray.
Yes.
Which X-rays direction is the most
Yes.
most useful to
Yes.
evaluate the cam, how much cam detection, right?
Yes. Yes.
Yeah.
Yes.
It depends on the patient, where the patient have cam deformity. The cam deformity is location is very individual. But
Okay.
for in my hand, the modified down view 45 degrees flexion and 20 degrees external rotation is a more higher sensitivity compared to another
Okay.
another direction like AP view or a cross-stable lateral view. The most important find X-ray direction is a modified down view. Modified.
Thank you, sir.
Yeah.
Thank you, sir. Thank you very
Yeah.
much. Uh,
Any other?
any of the panelist, any questions to Dr. Nakashima? Prashant,
Yeah,
sir.
so Dr. Sochi, I wanted to ask you to the all our viewers and who are the present in this webinar, just give the diagnostic test for the FAI. Clinic ID, what is the diagnostic? We have to see this. Okay. Clinically, this and radiologically, this. This is the test, and that is the diagnostic of the FAI. No need to do MRI and all. You understand, Dr. Soch?
Yeah, I understand. I understand. This lecture is only focused on radiographic, plain radiographic X-ray, the presentation. And MRI is also very helpful to diagnose the FAI because sometimes, X-ray only the bony deformity, but sometimes adolescent patient have if the X-rays looks good shape of femoral head neck junction, but the adolescent or child patient have it's a soft tissue cam region, like the very thick and the cartilage region, maybe growing to the bone. Those patients, the cam deformity, the MRI is really important to evaluate cam lesion. And also labrum care is also MRI is very helpful.
Yeah.
Is that okay?
No, just wanted to ask you the clinical evaluation. In clinical evaluation, did diagnosis stage for the cam lesion or FAI? Is the flexion internal rotation FIR?
Flexion, internal rotation, and
That is the
also yeah,
that is
it depends on the patient. But I think it's very difficult to uh, it's very difficult. Only clinical evaluation is it's very difficult to distinguish the FAI, diagnose the FAI.
okay. Okay.
Right.
Thank you.
Thank you, sir. Thank you,
Naresh, I
Dr.
think
Prashant, sir. Yes, sir. Sir, we would like to move on to the next topic. Is a case presentation by Dr. Purnachandra Tejaswi. Purnachandra, sir, please share your slides. He will be talking about a case of pincer deformity, most common seen pathology in Indian scenario. Over to you, Purna, sir.
Good evening, and very nice to see you, Professor Soshi Uchida and the team from Japan. It was a wonderful talk. So I'm Dr. Purna. I'm working in the city of Hyderabad in the south of India. Am I audible on the screen clear? Just to clarify.
Yes, sir. Yes,
Okay.
sir. You are clearly audible and visible as well.
So just to give a background of hip arthroscopy that has been happening in India, I would say we are still late starters. Hip arthroscopy is slowly picking up, and I think this is a very great initiative from IAS to really focus over the course of 2 or 3 months, so that we get to learn newer concept about hip arthroscopy and develop into our practice. And many of our colleagues and friends also start doing this, because we all know that this has taken in a big way in the Western world, including Japan. I have been practicing in India since 2019, when I came back from Canada from my fellowship. So we all know what is a pincer deformity and cam deformity, but do our patients present to us like this? when I was in Canada in my fellowship, I did my fellowship in Germany and Canada. Patients come, young patients, sports who are very active, come with typical groin pain. I would agree with Professor Uchida that there are also mixed set of complaints, but many patients come in with a fixed set of complaints, like where we can come to a diagnosis at the end of clinical examination, and top of that, when we add on with our imaging, we can confirm that this is a regular case of cam or pincer with a labral tear or some associated intra-articular pathology. But what I have seen in these 4 years in India is that our patients tend to come a bit late. That's around the late adulthood, that is around 40 to 50 years. They have little bit of early onset osteoarthritis already set in. I have very rarely seen a young patient with a typical cam or pincer deformity walking into my office for surgery. Of course, the realization is happening more and more. The patients are getting more and more aware. The colleagues are getting more and more aware, and nowadays there are referrals coming in the younger age group. But I would just tend to show a few cases what we come across in our regular day-to-day practice. We all know that pincers is a very significant source of pain, and in up to 21% of the 21% of general population, according to this paper. It can be due to various forms of pincer deformity. Let me go on to the patient. So this is a patient, 39-year-old female, presented with chronic pain in the hip joint. This is the AP view. You can see that there is a little bit of I'm not sure if I have the other images for this patient. There is a little bit of overgrowth on the pincer. There is a little bit of what do we call kind of calcification of the labrum. There is also a little bit of cam deformity that is very much visible. But our patients come at this stage where some of our colleagues would have advised total hip replacement. They would have gone for innumerable number of physiotherapy, no relief from pain, but they want some options other than a hip replacement at this young age. So I normally get 3D printed CAT scans for all my patients planning for hip arthroscopy. Here you can see that there is a subspine impingement and a pincer impingement between 11 and 1 o'clock position. 1 o'clock position, you can see that there is also a subspine, type 3 subspine as well. So this is my arthroscopic video. I'm seeing from the anterolateral portal, and once that is done, so you can see already there is a labral fraying that is seen from that is the mid anterior portal, and now I'm seeing from the the top, that is the mid anterior portal. I'm doing my capsulotomy on the anterolateral portal. There is already, you can see that as I envisioned on the CT scan, the labral damage is quite posterior to the midline, that is posterior to the 12 o'clock position, around from 9 o'clock or 10 o'clock, I would say, till the 12 o'clock position. This for just for information, the patient is in lateral position. The patient is on a Smith-Nephew traction table. So once that is done, I debride the labrum and I create the pericapsular space near the subspine for taking out my subspine impingement. I'm visualizing from the anterolateral portal, and the working is from the mid anterior portal. This is the 12 o'clock position, where the patient has a robust labrum in this particular scenario. Otherwise, I wouldn't repair labrum in this case. We pretty much don't do labral reconstructions in our country as of now. I'm not aware of others, but I have not done any in India as of now. And we need to, especially for subspine, we need to take a little bit of more, we need to clear a little bit of more capsule to visualize the pincer defect. In this case, I feel that the capsular stitches for traction help us a lot. And once that is done, as envisioned from my preoperative CT scan, I debride the pincer all the way from posterior 10 o'clock position to 12 or 1 o'clock position. And once that is done, I progress to a regular labral repair with Q-fix or any other type of anchors. So that's my first anchor, just around, I would say, 12:30 or 1 o'clock position. And I do normally 2 or 3 anchors based on the requirement. And once that is done, we just you can see that I remove the frills of the labrum that can cause pain in the patients, and progress with a small trimming of the cam to finish the surgery. And once that is done, we release the that's me identifying the cam deformity and identifying the cam deformity. This is very important to understand, that our preoperative scans are very important for us to identify where the cam deformity and pincer deformity extends from, because we are just having a 2-dimensional imaging in the theater, whereas we are dealing with the 3-dimensional deformity. So we need to understand where our deformity is, and to get a very good radiologic outcome and as well as good functional outcome for the patients. So these are the final images. This is my first case. Now the patient is around 1.5 years post-op. Patient is doing quite good, quite happy with the progress. We are planning for a second hip in another couple of months. So this is my second case. This is a 49-year-old male presented with left hip pain. He had difficulty of movements. So this is another typical kind of case that we deal with. The patient already underwent a total hip replacement on the opposite side 8 years back. He was pretty well doing good with the right side. Advised total hip for the left side also. However, he just was looking at options, and one of my colleague suggested him to just meet me for any other options. So examination, he had global restriction of movement with impingement test being positive. So this is his X-ray. The right side hip, I would not comment on that, because that is not what we're talking about. So left side, you could see a very big pincer deformity, global over coverage. There is posterior wall over coverage of the posterior wall over coverage of the acetabulum on the left side. So if I with the permission of the chair, if I could stop and ask my colleagues, Professor, what would you offer this patient at this age? Sir, could I?
How old this patient? How old this patient? How
40,
old? 48?
Yeah, 49.
49. The MRI, did you take MRI? MRI?
No, we tried taking an MRI, but because he had a total hip on the opposite side, it was too much artifacts. And
yeah, maybe I think as X-rays looks still joint space exists, but maybe severe cartilage damage in the joint, maybe total hip arthroplasties. But if the patient want to try to hip preservation surgery, the one option of the hip arthroscopy, I try to do hip arthroscopy. But this is a greater pincer type of impingement. Maybe we sometimes many of us cannot even traction because of greater pincer type of impingement. So in those cases, we perform peripheral first approaches, like Dr. Dientis from Germany. Do you know Dr. Dientis, Michael Dientis from Germany? Yeah, he does a peripheral first approach to get into the joint, and then the cam osteoplasty and the resection of the pincer, maybe labrum reconstruction, and then see how it works. That's what I'm thinking.
Yeah, I totally agree. I am in sync with you, Professor. Yes, I agree that in these cases we have to be ready with the peripheral compartment first, because as you say, it is very difficult to get the traction and the desired angle for the scope, for my arthroscope to go in. I feel appropriate counseling is very necessary in these patients, because even if you go ahead and do a hip arthroscopy, these people would end up with a hip replacement if they have a bad cartilage.
Yes.
I had a very proper discussion with the patient. We gave him different options. However, because there was good joint space on the the X-rays, both AP and lateral views, around 2 to 3 millimeter, we decided that we thought that this, of course, if it does not do any benefit, this will definitely not do any harm to the patient. This will not alter the outcome of a hip arthroplasty if he wants to undergo in a later stage. That is why we went ahead and did a hip arthroscopy for this guy. So this is in supine position. So this is, I could get some traction. We have to just be careful with the angulation of the needle. This is more angle than the normal straight trajectory we get in a hip arthroscopy. Here, this is what we call is the like ankylosing spondylitic variants, where there is global calcification of the entire labrum. You see, I'm seeing from the anterolateral portal, there is no labrum whatsoever, and it's very tough to get the mid-anterior portal in place. However, we could get that, and you, of course, you shift the arthroscope and do your capsulotomy slowly. And now back to the anterolateral portal. So there is just capsule. There was no labrum. Of course, I would want to do a labral reconstruction in this patient, but we decide not to go ahead with that because we are still dealing with initial parts of hip arthroscopy, and studies have shown that a labral debridement itself, patients do very well in, especially in these kinds of patients with early arthritis. So you take a lot of X-ray views to see. In these cases, this is a global pincer deformity. You can see that entire rim is ossified without no labrum whatsoever. So this always extends from medially almost till 9 o'clock position, almost goes back around till 2 o'clock or 3 o'clock position as well. But I don't think we need to resect the entire pincer, because that might not be pathological. We just resect that part of the pincer which in the anterolateral aspect and the postero superior aspect, which might cause impingement to the patient. And that is what I have. That is what I decided to in this case. This is so you can see that the normal cartilage is a landmark. The chondrolabral junction, what we call, is a landmark till where I would go to resect my posterior. This is already extending into the posterior, the pincer deformity. You finish the resection gradually. Start from medial, go superior, and come postero superiorly, and tend to finish your resection. So those are the final images. Sometimes it is pretty scary not to do a labral reconstruction, but we do not have the requisite instruments here, so we are still not doing it. So this is the final images. Now patient is around 2.5 years. Patient is around 2.5 years and doing pretty well. He is very happy. He is now 52, and and you saw that the cartilage was not that bad. It was maybe grade 2 chondral changes. So I would think that this patient may go on for 5 to 8 years before he decides to go or decides not to go for a hip replacement.
Okay. Great.
Thank you, Professor. So this is my last case. I don't have a video, just a few images, just to show that patients present very early, patients present late. So 29-year-old male, right hip pain since 1 year. He had total restriction of movements, difficulty in squatting and sitting, cross-legged. Tests were positive. He had global restriction of movement. So these are his X-rays. His left side is also pathologic, but we are dealing with the right side. Just imagine this is a 29-year-old male. The only thing that was positive in this case was there was a little bit of joint space over the anterior and the medial aspect, but you see that there is there is an anti-global overcoverage, there is a central osteophyte. So I was very skeptical about doing hip arthroscopy for this case. But this was a doctor's brother. I was in fact forced to attempt an arthroscopy for the arthroscopic surgery for this patient. So these are the CT scans. You can see that there is a global pincer. There is a global pincer deformity. For me, whenever I see an osteophyte, especially the central osteophyte, I generally that is like a contraindication for hip surgery for me, hip arthroscopy, because you don't tend to get any amount of traction whatsoever, and the cartilage would be pretty bad as well. But in this case, I had an MRI, but I couldn't find the images here. I have not posted. This is how I post the patient. We use the regular fracture table because you see that on the right side, whatever traction I give, the hip joint is not getting distracted. There is no hip joint distraction. There is a large shelf of bone over the lateral aspect. So in these cases, I think we need to be ready to go peripheral compartment first using the portal by Michael Dienst, as Dr. Professor said. And this is, so you can see the first image, the right side is the femoral head, and this is the shelf of acetabular rim covering the femoral head. So you slowly go resect it. Of course, there will be some amount of iatrogenic damage, but luckily most of it is the impinging part. You slowly go in this, you slowly resect the head, you slowly resect the rim to gain an acceptable amount of good impingement free motion. Once you do that, you slowly go from lateral to medial. You cannot resect the posterior part, but the superior part, and the patient has gained around 5 to 10 degree of internal rotation and 5 to 10 degree of external rotation. I agree that he would go on for a hip replacement, maybe in 1 year, 2 year, but he is able to sit comfortably in a chair now. So it is, as I said, if we do not do any harm, I think there is no wrong in going ahead and doing a hip arthroscopy to these kind of patients and see if we can help them. So in conclusion, what I have seen in my practice in hip arthroscopy in India is I do around 3 to 4 cases a month, around 45 to 50 a year. So patient present already in pretty advanced stage. They have advanced osteoarthritis, but that should not stop us from giving them options of hip preservation. This is what we call as the ankylosing spondylitic variants, where there is excessive labral calcifications akin to calcific tendinitis of the shoulder and other joints. We have to be prepared to enter the peripheral compartment first, which is a very important and good technique to have. However, good joint space is a prerequisite for hip arthroscopy, and if we follow the basic steps, and what I have seen in my small amount of practice is that patients do pretty well. Thank you, and I would thank all the team members from IAS for this opportunity. This is a very excellent program that has been going on and teaching all of us. Thank you very much.
Thank you so much.
Thank you very much, Dr. Purna.
Great talk.
Thank you. Thank you, Professor.
Any questions? Any questions from the panel?
Okay, so
it was all great case.
Okay. Can I ask a question?
Yeah, please,
Yeah.
please go ahead, sir.
Yeah. Thank you very much for your nice talk. And your all cases have a labrum ossification or global pincer. Your first cases is looks like also acetabuli, and I wonder if the prevalence of global pincer type impingement in India. Have you ever looked at epidemiologies?
Yeah, that's.
I think it looks like much higher than in Japan, maybe.
Oh yeah. That's a fantastic observation. I think you have given us a very interesting topic to look at and see if that is significant in our population. It's definitely higher than the Western population or in Japanese population, I would say, because most of these patients also have other joint pains. So you need to significantly see if that is a source of pain in these patients. You need to really exclude the other sources of joint pain. Whatever you told in your talk, the diagnostic injection is an excellent option. I do ultrasound guided injections to see if the pain is coming from the hip, and if there is good relief of pain with the diagnostic injection, then I go ahead and do the surgery. But downfall of that is some patients are so happy with the injection that they don't turn up for surgery.
Yeah, thank you.
Can I ask one question to Purna, sir?
Sure.
Yeah, Dr. Tirth, please go ahead.
Yes, sir, for example, in such cases, if you have attempted hip arthroscopy and if you see that there is a kind of grade 4 chondral lesion, then how do you address this kind of lesion? And also, one more question, like, do you do any concomitant core decompression or injecting zoledronic acid in femoral head or scooping out the lesion like that?
Very nice question, Dr. T. I think your question has two parts. Number one is the osteochondral lesions as part of doing hip arthroscopy, regular hip arthroscopy. I would be very careful. I would look at my MRIs and other investigations even beforehand to see if there is any isolated osteochondral defect that I need to deal with before the surgery itself. Because the reason being, some osteochondral defects are very difficult to reach with the regular instruments that we have available in India. So I would be having everything beforehand. If there is a osteochondral defect I have to deal with, that's said and done. If I find that there is any grade 3 or grade 4 chondral defect, a global chondral defect, I have not seen for an isolated defect, I would plan well ahead. But if there is a global chondral damage, I would go ahead and give a BMAC injection, which is converted to a gel. That is what I have done. But for isolated chondral defect, I plan well ahead. I do microfractures, and we don't have any other things like Cargel or any other options in India as of now. So what I have done is just BMAC for isolated chondral defect. Regarding the second part, dealing with AVN and intra-articular lesions, I think Dr. Prashant sir has already told about that. We are also coming up with a paper. I have stopped doing that. Initially, I was doing hip arthroscopes for all my AVN patients. I've stopped doing that because personally, I feel that was not very beneficial, and it is taking a lot of surgical time. Of course, there is, as Dr. Professor also pointed out, there is a lot of intra-articular pathology involved. There is synovitis, there is labral tears, but how much of this is contributing to the pathology is the question. So I would deal with the primary part, that is the avascular necrotic part first. And if the patient does well, maybe patient hip is saved, maybe after 1 year, 2 years down the line, I would offer a hip arthroscopy to him. That is my experience on past cases, whatever I have done.
Thank you, sir.
Thank you very much, sir. Dr. Ayyappan sir also joined us as a moderator. Sir, any questions you have?
Sorry for coming in late, but I got stuck in a surgery. It's nice to see Professor Uchida after a long time. Okay, last time I saw him was in Yesikas. It was a great discussion. I don't think I'll want to ask anything now.
Thank you, sir. Prashant sir, any questions?
No. Thank you, sir. Nice cases, Purna.
Thank you very much, sir. Thank you very much.
Purna, nice cases, yeah, very nice. Okay, so very interesting and they're nice cases. Great work you're doing.
Thank you very much. Thank you very much, sir.
Thank you very much, sir. Thank you. In this context, I would like to conclude today's webinar. I thank Dr. Sandeep Biraris, Dr. Rajiv Raman sir, Secretary of IAS, Dr. Ayyappan sir and Dr. Prashant sir for moderating this wonderful session, and our expert faculty, Professor Soshi Uchida, Dr. Hirotaka Nakashima for giving their wonderful expert talks, And finally, Dr. Purnachandra sir for sharing his experience on pincer deformity with all the wonderful cases. I thank Tirth as well. Thank you very much. Bye. Good night.
Thank you.
Good night. Good night,
Bye.
sir. Good night, Professor
Bye.
Uchida.
Good night.
Bye. Thank you for all for your joining. Thank you.
Thanks all.